Thank you, Ben and Preeti, for your very thoughtful summary of your recent Lancet article, and I welcome the invitation that I've had to present some alternative views, but really reiterate what Michael said, that the intent of this session is to promote thoughtful, respectful conversation and discussion of what we all know is a very complex and nuanced subject. My response is going to focus on the words, the voices of clinicians and lived experience provided in blogs, letters and newsletters responding to your article. But first, what's in a name? A name is defined as a word or a group of words by which a person is known, addressed or referred to. In contrast, a label is a word or a phrase that usually refers to a group of people for classification. But names and labels can be used interchangeably. Both have value, but both can be used inappropriately to cause harm, including stigmatisation. Our own names provide us with a personal and legal identity, distinguish us from others, denote our family lineage, and may identify our ethnic heritage or our gender. The legal right to be registered at birth and to have a name are recognised in international law, including the Convention for the Rights of the Child and the Universal Declaration of Human Rights. In a blatant disregard for human rights, I once witnessed the use of boat numbers, boat ID numbers, rather than names for children seeking asylum in Australia who were being held in mandatory detention. One 16-year-old boy said of this dehumanising behaviour, people were called by boat IDs. People had no value. In medicine, names are used to allow people living with a condition, their health professionals, families and teachers, to better understand the cause of the disorder, its presentation, the method of diagnosis, the most effective treatment, prognosis, prevention or heritability. And as clinicians and researchers, we have a real challenge ahead of us, particularly in this field, deciphering the myriad of names that we currently use to characterise harms from PAE. Think fetal alcohol syndrome, prenatal alcohol effects, partial fetal alcohol syndrome, alcohol-related neurodevelopmental disorder, alcohol-related birth defects, static encephalopathy and neurobehavioural disorder associated with alcohol. It's a minefield. The authors of the Lancet paper said they had major concerns about the continued use of the name fetal alcohol spectrum disorder as a diagnostic term, and you've made that case very well. The name FASD came into use in about 2000 to acknowledge that fetal alcohol syndrome was not the only effect of prenatal alcohol exposure, but there was a spectrum of the disorder, and that children exposed or people exposed to prenatal alcohol exposure may have neurodevelopmental disorder in the absence of facial and other physical features. However, even this name is used differently in different countries. So in Canada and in Australia, we use it as a diagnosis. In the States, you use it as an umbrella term. And this in itself is a problem. Now, a practical barrier to changing the name is that it is understood and used globally by people with lived experience, by governments and by professional bodies. After all, we are attending the 9th International Research Conference on FASD, hosted by FASD United, attended by parent organisations such as No FASD, Can FASD, at which research is being presented by CFASD, so we're pretty embedded in that name. At the 2024 Seattle meeting on FASD, young adults living with FASD, the changemakers, begged the audience, whatever you do, don't mess with the name. There have been so many names. We know that we have FASD. We understand what that means for us. It helps us own our diagnosis and work with it. An adult with FASD who also has an adopted child with the diagnosis said in the response to the Lancet article, "Upon reading this article, I was struck by a sense of invalidation of the symptoms, the condition itself, and the profound impact it can have. The article seemed to downplay the significance of the diagnosis, attributing symptoms to other causes. for individuals with FASD who already face misdiagnosis and misunderstanding, such invalidation can be particularly damaging. Now, it is, of course, also a human right to receive an accurate diagnosis. And yesterday, in their presentation, or the day before, the changemakers asked us, why would you withhold a truthful diagnosis even if it's potentially stigmatising? The names suicide, drug use, alcoholism, HIV, all make some people uncomfortable, but you still use them. You don't pretend they're something else just to make someone feel more comfortable. Not naming something doesn't change what it is. That's just dishonest. In a similar vein, an Aboriginal elder said to me, people in our community who don't acknowledge FASD are being dishonest to themselves and their children. There may be a stigma associated with the name, but we need to face up to the reality that alcohol does cause harm, not just to our people, but to non-Indigenous people as well. A young adult with FASD with a strong relationship to her biological mother said, a diagnosis with FASD is not an accusation, it's an explanation. It does not add to the weight of an already difficult journey. It reveals the truth beneath it. In giving her perspective, one birth mother wrote, with the realisation that he had sustained prenatal alcohol exposure prior to my pregnancy recognition came emotions of guilt, fear, shame and grief. But the FASD diagnosis brought validation, insight and a newfound understanding of the struggles our son had been experiencing, and respect and love for how hard he had tried to live up to our unrealistic expectations. Research does suggest that understanding the cause of a neurodisability in your child does allow realistic expectations and is one of the best determinants of them reaching their potential. The Lancet article suggested that the name FASD contributes to a culture of racism, and you've just addressed that, and discrimination in marginalised people. In Australia, we go to great lengths to emphasise that FASD is not a condition exclusively of Indigenous people, but disproportionately affects all marginalised groups wherever alcohol is available. Having said that, alcohol is often used to hide the pain of historic trauma associated with colonisation and with ongoing racism. I would contend that the culture of racism is more likely to lead to alcohol use and FASD than FASD diagnosis contributing to racism. One Australian Aboriginal leader said to me, I think it's racist not to give our kids an FASD diagnosis. We need to understand why they are challenged, which mums need help with their drinking, and how we should adjust what we can expect from the kids at home and at school. Another said, in our communities we have known about grog babies, which is what they call them, for decades. We don't see them as disabled, we see them as special kids with special needs who need special supports. We don't want to shame or blame mothers, we want to help them. And according to one social worker from Central Australia, the key issue is not the diagnosis, but the lack of adequate resources and culturally appropriate services to address the needs of Indigenous families. In exploring the use and misuse of labels, sociologists in the 1960s developed a labelling theory. They suggested that the behaviour of a group of individuals was influenced by the label used to describe them. A label was a self-fulfilling prophecy. For example, they postulated that the label criminal promoted deviant behaviour. That is, if you were called a criminal, you engaged in criminal acts, and that the label mental health led an individual to be unpredictable and dangerous. However, they then realised that it was not the label that determined the outcome, but society's response, and that labels could be beneficial if societal attitudes could be changed. In the case of the criminal, the label could enable rehabilitation, and promote restorative justice if only society could reject the moral indignation and replace that with tolerance. Similarly, if a society showed compassion, the label of mental illness could lead to appropriate treatment and care. In line with this, one young woman with FASD said, "A diagnosis should not be hindered by the perceived burden of an undesirable label from those who do not carry it. It is not fetal alcohol that stigmatises and marginalises. It's people and society that do that." Although the Lancet authors write that FASD-specific supports of funding can create barriers to care, this doesn't seem to be the clinical or lived experience. In their response to the Lancet article, a young adult living with FASD said, "A diagnosis of FASD is the key that unlocks understanding and the gateway to support and the first step to healing and hope." Similarly, a group of New Zealand psychologists wrote, "We've supported a wonderful group of individuals with FASD who have found their confidence and voices to speak out against inequity. Diagnosis leads them to self-awareness and access to support." One clinician in Australia responded, "In the National Disability Insurance Scheme, FASD is now included for funding as a condition that results in a permanent impairment. Thus, the diagnosis increases the chance of receiving funding for early intervention and support." I should say that if you don't have a diagnosis, you are still entitled to support by that scheme for functional impairment. They continued, in 2023, FASD was also recognised as a complex neurodisability within the medical benefits schedule, allowing GPs, paediatricians and psychiatrists to provide detailed assessments, reports and referrals for allied health therapy. A foster mum said that the name can also bring families together. "I'm a member of numerous online support groups for individuals affected by FASD and those who support them. Altering the name will disconnect the thousands of individuals in this global community who provide mutual support." The National Organisation for FASD Australia said, "The label is key to opening the door to deeper understanding." We have been heartened in recent years to see a heightened awareness of FASD. The National Every Moment Matters campaign has increased recognition of the risks of alcohol consumption in pregnancy and the fact that prenatal alcohol exposure can result in FASD. To see this progress in awareness and support undermined by changing the diagnostic term for this condition would be a retrograde step. The diagnosis can also assist in understanding in the justice system. One foster mother of an adult with FASD in her 40s wrote, "Now is not the time to change the name. After years of lack of knowledge and understanding of FASD, this diagnosis has finally become more widely understood. Our daughter was recently charged with a crime that was directly related to symptoms of her disability. Because the judge was educated about FASD, she was rightly found to be unfit to plead, which led to more appropriate community support being put in place." Now, names should be used to the best interest of the individual. Just as we can choose whether to use the names we were given at birth, we can choose to change them by deed poll, with marriage or after gender transition. In your article, you spoke of a biological mother who was trying to move on from her past, feeling shame at revealing her child's FASD diagnosis and hence her own alcohol use. In response to this, one clinician wrote, "This situation should not arise. If a child fulfills criteria for a diagnosis in our clinic, we discuss family preferences about how the diagnosis should be conveyed in the medical report to the school and to other professionals. It is their choice whether the term FASD or an alternative is used and who to share it with. And this may mean using different labels for different audiences and different contexts. It's up to us as clinicians to train parents how to use medical information about their child wisely in a non-stigmatising way that is socially appropriate and as necessary to benefit their child. You also asserted that we should move towards a broader diagnostic term, such as neurodevelopmental disorder with qualifiers, and of course that will be relevant in many situations. This raises the question to you all, is your approach to taxonomy as a lumper or a splitter? Lumpers tend to categorise things in fewer, larger chunks, which are often imperfect. It is said, and I like this, that lumpers think splitters are neurotic, and splitters think lumpers are careless. In a letter to the New Zealand Listener entitled "No Labels, Please," one clinical psychologist of 30 years made his position clear. He said, "I studiously avoided diagnosing and labelling children who some of my colleagues in the health sector believed had ADHD, ADD, ASD, ODD, CD, or even FASD. A child psychiatrist provided an alternative view. Tackling a child's development and psychiatric needs has a huge impact on their future quality of life. Lumping ignores the decades of research that have delineated various neurodevelopmental disorders and enabled therapeutic gains, and so does children a disservice. It may deny children access to medications for ADHD, speech therapy for language disorder, funding and social emotional support for ASD, or educational interventions for intellectual disability and specific learning disabilities." In a letter to The Lancet, a group of clinician researchers said, "The viewpoint denies the importance of alcohol as a neurobehavioural teratogen, and that in FASD, the brain and behaviour are different from other neurodevelopmental disorders. FASD is a unique disability." One parent who also lives with FASD said, "Expecting everyone to conform to a single standard without accounting for differences is like wearing shoes that don't fit, leading to discomfort, frustration, and missed opportunities." Beyond neurodevelopmental disorders, we know FASD is associated with severe microcephaly, facial dysmorphology, birth defects, and sensory impairment, epilepsy, growth failure, and cerebral palsy. One birth mother raised this issue. "As a spectrum disorder impacting the brain and the body, we must avoid focusing on alternative names such as neurodevelopmental disorder, which do not factor in the varied whole-of-body disorder." As we heard from Professor Stoner yesterday, PAE, likely through epigenetic mechanisms, increases the risk of a range of organic disorders in adults: renal, metabolic, endocrine, cardiac and mental health, and cancer, that would not be expected in other neurodevelopmental disorders, but require careful surveillance in FASD. FASD, the national organisation, responded to The Lancet with 7 key reasons why they thought the diagnostic term should be continued to be used, and many of these were exemplified in responses to the article. First one was it's a clear and actionable diagnosis, and as one foster parent, also with a child, outlined that in childhood, the diagnosis helps shape interventions, educational accommodations and behaviour support. During adolescence and adulthood, it ensures that individuals receive proper care, employment support and life skills. Throughout life, an accurate diagnosis promotes empathy and a better understanding of each person's strengths and challenges. It improves long-term outcomes for individuals and their communities. The second point from FASD was this supports evidence of alcohol as a teratogen. The FASD changemakers reiterated this yesterday. The difficulties caused by alcohol may exist in the absence of other complex interactions and experiences. Neither of us had ACEs, but we still have the things that go with FASD. The third point was that stigma should be reduced by education, not changing the terminology. FASD said, although it is true and problematic that FASD is highly stigmatised, this issue lies not in the diagnosis itself, but in harmful stereotypes perpetuated at the societal level. Rather than eliminating FASD as a diagnostic term, efforts should focus on better education and reduce judgment among service providers and the public. Point 4 was that diagnosis improves health equality. In their response to the Lancet article, FASD United said that abandoning the name may further decrease health equality. For example, given that many US states do not even recognise an FASD diagnosis as a qualifying condition for services, it's asking a lot for these states to make services eligible to people without a formal diagnosis and without confirmed PAE. Point 5 was it's a gateway to services, and this was certainly agreed to by social worker Prue Walker, who related the story of a young man recently diagnosed. For the first time, this young man has been able to access disability supports despite having developmental issues as a child. His FASD diagnosis only came at age 17. Finally, the diagnosis is critical for prevention. As one social worker blogged, without knowledge of the FASD diagnosis, we miss the opportunity for preventing future alcohol-exposed pregnancies. The Lancet authors state that by using the diagnosis of FASD, clinicians fail to capture progress made in collective understanding of neurodevelopment through advances in genetics and understanding of trauma and adversity. And I think all the clinicians in this room would agree that making an FASD diagnosis is challenging. This statement, however, fails to appreciate how little we do understand about the epigenetics and the genetics of neurodevelopmental disorders. And I think it also underestimates the care taken by all of us as clinicians when we make a medical diagnosis to adhere to that bio-psycho-social, developmental and cultural approach that accounts for all the contributors to the physical and behavioural phenotype that you've mentioned in your slides. In our clinic, we identify the strengths in all children and, based on a comprehensive assessment, identify their needs. All children have a comprehensive history, including looking for adverse childhood experiences, a thorough physical examination, laboratory testing to look for other conditions that may contribute to neurodevelopmental disorder, and genetic testing. Then, collectively, the clinical judgment is used by the multidisciplinary team to weigh up the relative risks and contributions of prenatal and postnatal exposures and to make a diagnosis. As there is no definitive diagnostic test for FASD, the diagnosis is not made lightly, and certainly if there is uncertainty about PAE as the major contributor, or if the diagnosis is not accepted by the parents. The important thing is to describe the needs of that child and get them the appropriate early intervention. As one group of clinician researchers said, emerging evidence increasingly allows separation between the neurobehavioural correlates of postnatal adversity and FASD. Adverse childhood experiences don't cause birth defects or severe microcephaly, and much trauma research inadequately controls for prenatal alcohol exposure. Finally, we must address alcohol use in society. Unlike other neurodevelopmental disorders, we can reproduce the phenotype of FASD using preclinical models of prenatal alcohol exposure in which we can eliminate other exposures. One birth mother said, "It is crucial FASD remains a diagnostic term. To remove the focus on alcohol in the diagnosis removes 50 years of momentum to create a clear public health message." Another said, well-meaning people wanting to change the name for fear of stigmatising the mother and or the child need to reflect perhaps on their personal bias, the deep-set love affair we all have with alcohol. The skill development required to have courageous conversations should be where the focus is placed. An adoptive father agreed. Removing the terminology of FASD will negatively impact prevention efforts. It's alcohol that causes FASD and silence that contributes. A young adult living with FASD did not want to let the alcohol industry off the hook. She said, "We live in a society awash with the insidious influence of a powerful multi-billion-dollar alcohol industry where ignorance about the consequences of prenatal alcohol exposure has thrived. Stripping FASD of its name removes accountability and cripples prevention efforts. Removing causation absolves the alcohol industry of responsibility for the harm that their products cause." Alcohol should be demonised, not mothers. We must legislate evidence-based policies that we know will minimise harm from alcohol and hold to account the industry and the politicians who accept their support. On balance, I think the name FASD currently offers more benefits than harms and should be maintained. But when we make this diagnosis, we must do so with care and compassion, without shaming and blaming, ensuring that we value the strengths of each individual and their family and give them the choice about when and how to use the name. Thank you.
So we're going to take a few minutes now to hear from some people with living and lived experience. Laura Bousquet will go first. Welcome.
Thank you so much for having me, first of all. And right then, I've got 5 minutes, but 60 years of experience. So let's see how we go with this. So I want to share the challenges individuals with FASD face due to misconceptions and systematic barriers. This isn't just an academic discussion. This is about real people with real diagnosis, like my son and myself, who must navigate not just the diagnosis itself, but also the systems of care and societal expectations. I will discuss points of agreement and disagreement with the Lancet article and look ahead at how we can bridge the gap between research and living experience. So when I think someone had mentioned it earlier, when I first read this article, I did feel a deep sense of invalidation, not just for myself, but for all individuals living with FASD for the last 50 years of all the research that has been done. Research is vital, but when it dismisses the reality of our experience, it risks reinforcing harmful misconceptions. FASD is a whole body diagnosis, not just a set of behaviors, social, emotional, and cognitive. The assumption that symptoms stem from other causes ignores the necessity of accommodations, tailored supports, leaving many without the help they desperately need. With that said, there were multiple points in the article that I did agree with. FASD is complex. Too often, professionals fail to recognize the vast impact. Proper diagnosis is not about labeling. It's about unlocking doors to support healthcare and better outcomes. One-size-fits-all approach does not work. Most importantly, individuals with a living experience must have a seat at the table or stand at the podium, in this case, and be heard. As researchers and academics, I urge you to collaborate with those who live this reality daily, as we do not get to put FASD up on a shelf and go garden. We live with it 24/7. So I want to look at that last part, the acknowledging living experience. So everyone in the room here, think about why you're here, right? Are you here because your experience is solely involving research? Is it because you work in an FASD clinic? Or is it because your life and your child's life depends on it? I had some distinct differences and viewpoints as well. I believe that not recognizing FASD as a proper medical diagnosis is potentially harmful. If we remove medical legitimacy, we remove access to support. If medical providers are not trained in FASD, how can we expect to prevent potential age-related conditions caused by PAE? This is a lifespan condition. Womb to tomb. Children with FASD grow into adults with FASD, and medical providers need to be aware of potential health challenges throughout the lifespan. Ignoring FASD because it doesn't fit into a traditional diagnostic framework or funding structures is only going to make the barriers to healthcare harder to break down. This is exactly why FASD United is working hard to get the FASD Respect Act passed. Additionally, accurate diagnosis is a cornerstone of effective support. In childhood, it ensures interventions and tailored to the individual's needs. In adolescence and adulthood, it continues to guide access to education, employment, life skills. It's not just about naming a condition, it's about providing the right tools to succeed. A misdiagnosis or no diagnosis at all can leave individuals without the resources they need, forcing them to navigate systems that were never designed with them in mind. Having the correct and accurate diagnosis can change and save lives. I'm going to say that again. Having the correct and accurate diagnosis can change and save lives. While ACEs and environmental factors matter, they don't negate the need for an accurate FASD diagnosis. FASD can happen in any population across any socioeconomic status, even with children that would not have high ACE scores. We cannot allow stigma to prevent parents and caregivers from seeking the truth about their children's needs, nor can we lose the diagnosis because it is associated with stigma. Instead of ignoring or hiding this topic because of stigma, we need to get to the bottom of why the stigma is there in the first place and spend our efforts normalizing and educating. The question now is, how do we move forward? The answer lies in education, policy, change, and advocacy. We must ensure that all professionals, medical, legal, education, understand FASD's complexities. Policy changes require engagement from researchers, families, and advocates. Support networks must be strengthened so that those affected are not isolated. And above all, we must shift the narrative. FASD is real. Those with it deserve recognition and support. Let's educate the systems of care, create support paradigm instead of erasing the diagnosis. FASD is not just a topic for research. It's a living reality for millions of individuals and families. Dismissing its impact hinders progress. Validation, research, and systematic change drive meaningful outcomes. I challenge you to ask the difficult questions, to acknowledge the complexity of the diagnosis, and to ensure that research translates into action. I invite you to join me in advocating for education, policy change, and partnerships that will make a difference in the lives of individuals like my son and myself. Thank you for listening, and I hope we can work together to create real change. Families like mine are desperate for help.
Next, we're going to hear from Jenelle McMillan.
So, asking difficult questions about FASD in the context of the family, the mother, and the systems in which they live. There's so many questions that arise, and with respect to those who have created this paper, I wish to reflect on their work and to share some of my lived experience. And I'm one of these people that writes in every different direction on every piece of paper, and I have probably 7,000 Post-it notes since I first read this, but I tried to pull it all together. So I think that we can all agree that alcohol is a teratogen. I think we can agree that women drink alcohol, not all women. Women usually do not drink alone. Pregnancies are not all planned. Women do not always know the moment they conceive. Pregnancy tests can be falsely negative, and the majority of women stop drinking as soon as they hear, "Congratulations, you're pregnant." So just by a show of hands, would you agree with those ideas? Okay, I'm on the right track. So I have many little notes, and I'm not going to get to speak to all of them. But what I wanted to be able to say is that a medical diagnostic term that identifies maternal alcohol use as the primary cause of a person's functional limitations outweighs the benefits. I learned that my son was on the spectrum of FASD because I was working as a family support worker in a teen parenting program, and they said, "You don't fit here." That was in 1995. But the executive director of the Friendship Center said, "But you do fit here." He says, "We have a job on Monday that you can apply for. Take the weekend and learn everything you can about fetal alcohol syndrome." I said, "I know nothing about fetal alcohol syndrome." He says, "Great, you've got the weekend." Little did I know that my life would be changed forever. As I started reading, I started saying, "This is my son. Oh, and this is my son. And this is my son, and this is my son, and this is my son." And holy cow, pretty soon, I am in tears recognizing my experience and not knowing that the alcohol that I had consumed had caused the damage to my son. So pregnancy is complex. Drinking is complex. I didn't drink all the time. I only drank when I was overwhelmed. But when I drank, I would drink 26 ounces a day at about 110 pounds. Then I wouldn't drink again for months. At this point in time, I was a journaler. So I pretty much have a detailed picture of my drinking and when I drank, how much I drank, who I drank with, and why I was drinking. So between day 18 and 21 of my pregnancy, as it was later counted back, I had drank 26 ounces of alcohol a day. My son was born with his heart coming in front to back. He had ASD and VSD and PDA and I don't even know how to say all the other things, but his heart was affected. He also had his organs in the reverse order. He had his stomach and intestines that didn't connect to each other. So when they went to operate and repair his stomach to his intestines, they took out his appendix, because who going into an ER saying, "I'm in pain and I'm holding an upper side of my left instead of lower right side is going to be treated for appendicitis." So there was a lot of complex things, which later was clearly explained by alcohol use during that time period. And I really like the zebrafish, because to me that kind of really validates that we need to have our public health messages that are reminding us. And I know I kind of say it flippantly and I kind of joke, but you know, you have to choose, either have sex or drink, right? Don't do the two together. And you know, make sure you have a pregnancy test in between to make sure you haven't gotten pregnant, right? But for me, that wouldn't have mattered, because my pregnancy tests were negative. The only thing that protected my son was the fact that I was no longer able to smell the smell of alcohol. Anytime I smelled alcohol, I would get sick. Anytime I would have raw meat, like touch raw meat, I'd be sick. I have been hunting my entire life. I have been butchering my entire life, and all of a sudden I can't touch raw meat. There's something seriously wrong with me. But the doctor kept telling me, "You're not pregnant." And he kept sending me away, and I kept coming back, and I kept saying, "I think I must be pregnant, because nobody else can, you know, stop me from eating meat or cooking meat." And the fact that I couldn't drink when I was upset was disturbing. It finally took me, I was in my 3rd month, and I did a urine test. It was positive. I went back to my doctor, and he says, oh, well, you tried hard enough. And this was my wonderful system. And then he did an ultrasound, and I was 13 weeks pregnant. So it was, you know, fighting that system of, you know, do we know or not know when we're pregnant? And is there other possibilities that prevent us from knowing that we're pregnant? And in my case, it was. I didn't drink any more alcohol during my pregnancy, but that was enough to create a lifetime of differences for my son. He was diagnosed with alcohol-related birth defects and alcohol-related neurodevelopmental disorder. He's now 35, and he functions with support, and he's had a lot of support growing up. I have 2 other children who have been diagnosed, and I have a granddaughter who's been diagnosed on the spectrum. And I also asked them, I said, so what would it mean to you to change the name now? And my one daughter sat there and she thought about it a lot, and she said, well, it would change who I am. And then I asked her how. And she said, because people understand me and give me support, and my daughter's 38, people understand me and give me support because they know what it means to have fetal alcohol syndrome. So if they don't know what that means, how will they give me the support that I need? Good question. But her adopted daughter, who also was diagnosed with fetal alcohol syndrome, she says, I absolutely hate having to tell the school that she has a diagnosis of FAS. She says, because the school are buttheads. It doesn't matter because they don't listen to what they need to do to support her. So would any diagnosis work at all to give her what she needs? I don't know, I put that one back out there. My son doesn't use his diagnosis in his everyday, but he receives disability support because of that diagnosis. And that has made all the difference in his life in being able to have jobs where he can work 2 days a week, because that's all that he can handle. Then I'm going to flip back into this part of the fetal alcohol spectrum disorders as a diagnostic term perpetuates racism and discrimination amongst marginalized groups that experience oppression within existing systems of healthcare, education, and social support, and might prevent the recognition of other factors contributing to a child's health or developmental presentations. And one of my questions is, who writes the messages? In a lot of our communities in BC, the reason why there's a lot of diagnosis in First Nations communities is because they asked for it. They knew something was going on, they recognized something was going on, and they asked for help. Because that's what the warriors do, right? That's what a community does. It looks to look after all of its members in a village. And so perhaps that identifying some of those pieces, we also look at colonization, and we look at the marginalized groups with historical and intergenerational trauma. We rarely have access to trauma treatment. We rarely have access to even our own ceremonies. And that's a result of residential schools, the 60s scoop, the prohibition of potlatching and sun dancing and all those neat things that came. But how then do we create answers if we don't step forward? And one other thing I saw here was, oh, sorry, I'm jumping to the page. Pregnancy, fetal health, infant health, and prenatal alcohol exposure have traditionally, and me, because traditional is a big word in my world, so traditionally, whose traditions? is it medical traditions? Is that how the lens I'm supposed to understand it in? Have considered the responsibilities of the mother. In our teachings, the man's role in pregnancy is to be the warrior who protects the womb and the family. How do we then give this back to our people and other people, that we all have a role in this, and that role starts with thinking before we become pregnant and educating our children and youth, and what is I think that what's interfered with this is the loss of rites of passage. How do we tell our young people? My young granddaughter, she was 10 and she got her moon. Now, what a big celebration, right? How do we keep her safe, right? How do we help her to understand that what a gift she now has, and her responsibility as a young woman to carry that gift when she has FASD as well. So thinking about, how do we protect her? How do we help her to make herself a sacred being, so she makes those choices of who can be in her space and who can be part of her closest inner circle, who can enter her, is what we teach in our first year of training in rites of passage. So colonization has affected this. It has changed it, but we're trying to recall it. We're trying to bring it back. We're trying to bring that health back into our pregnancies, into the roles of the matriarchs. And not only do the women have to go through training, the men go through training. So men also have to learn how to treat and respect even their sisters when they're on their moon time. There's no teasing, there's no bugging, there's no picking at a young woman on her moon time, because she's learning how to be in control of her power. She can't do that if she is being allowed to be picked at, so that her emotions can run crazy. How do we bring that back? How do we give that back to her? How do we wrap her and protect her? So we, like in our community, we are working on bringing those things back. And so that is bringing pregnancy back to all of us. It's not the responsibility of the mother. And in fact, it is all of us who share in the responsibility that we are looking after women if they are in their partying years, let's say, and protecting them. And how do we help them to safely go about this, or choose a traditional dancing path, or be part of ceremony so that they choose not to use alcohol at all. So I'm not saying that it's, a good or bad thing. I'm just saying it is a thing. And I have almost 31 years of sobriety now because my elders wrapped me in a blanket and said, choose your path. And just one last thing I want to say is there a need for a medical diagnosis and a community name? Because humans are judgmental, right? I agree. Humans are very judgmental, and it begins with a false narrative. And you never see themselves or their family members being in a similar narrative. So if we take the name away, if we change it or we hide it, are we doing a disservice to the greater piece, or are we needing to change the narrative, changing the way people perceive and understand that they need to change their perspectives and be able to understand that it could be any one of you. It's not this idea, which has been stereotyped, that you have to be drunk and falling down drunk on a regular basis to have a child affected by prenatal exposure to alcohol. So, thank you.
Thank you so much. Our next speaker is Lori Vitale Cox. Thank you.
Hello, everybody. Thank you for having me. And I'm not Indigenous myself, but I'm a settler to Turtle Island, but I am a mixed breed of Italian and Ukrainian Jewish. My parents were immigrants, and I'm connected, though, by work, friendship, and blood to the Elsipogtog community. My granddaughter lives with her mom in Elsipogtog First Nation, and she's Micmac and Navajo. Her uncle was one of the first youth diagnosed in the community more than 25 years ago. And I'm also married to a man who was diagnosed as an adult with FASD. So I'm the director of the Eastern Door Center. I came to the community as the school psychologist in the mid-90s after a rash of suicides, and did a prevalence study, and it was 20% of the population were diagnosed with FASD. And it was the community that wanted the diagnosis because they wanted, they didn't know about the prenatal alcohol, but the doctors never told the women about not drinking, and so they were drinking. And so I think that that's an important, this is coming from the community. Anyway, so this is an issue. It's an issue that's really close to my heart, you know, just in terms of my family and the community and what I've learned there. But I really understand over the years the concerns of the co-authors, Ben and Preeti, because I've had them myself. Talking, I mean, for years, what can we do this? Like FASD, it's such an uncomfortable name. Is there a way of dealing with this because of the stigma, you know? And stigma is something that we all grapple with, all of us. And we are all attempting to find ways around it and the best ways of dealing with it. Now, the answer that is suggested, and it's something that I myself, again, has thought about the name, I think it's coming from the mind and not really from the heart. As Pascal, you know, has said, the heart has its reasons that the reason doesn't understand. And there is a suggestion then that there are so many risk factors, you know? I mean, how do we even know that PAE is the one, you know? And this really has been swirling around for a long time, and it's true. We saw the slides. There's many, many things that are coming in there. There's the suggestion that perhaps we should eliminate the term FASD and give support based on function rather than diagnosis. And yes, again, it seems to make logical sense, but like a lot of things conceptual, it's very limited in scope. And I know, though, that this is a question that's dividing us instead of bringing us closer together. And this is a time that we need to be closer together. We need to gather together closer. We need to listen and work together for this. If we listen to the people who have FASD themselves, like my husband, they are telling us that diagnosis is like a light, helping them navigate the world. And I agree, because it saved my marriage, I can tell you. It was like a light. I was ready to separate. I was ready to leave. But it came and it really helped me understand where things were at. And, you know, so some people are angry, very angry, and the reality, though, is that all of us are on the same side. Ben, Preeti, Liz, you know, Michael, Jenelle, all of us want the best for people living with PAE. So the question is how do we get around the stigma? How do we get around the shame and the blame of others? How do we get around the fear that medical professionals often have about asking mothers about alcohol when they were pregnant, or maybe are pregnant, or maybe want to be? Or when children end up with behavior problems, about asking the mothers whether or not that might be an issue. Now, Ben and Preeti suggest that maybe it would be best to give a diagnosis of NDD, not FASD. give support based on function or lack of it. Well, I can tell you, that's what it was like in Elsipogtog before we did the diagnosis. We didn't have any support because there was dysfunction, but it wasn't quite enough. A functional approach does not really work with FASD, because often, if you're involved in the assessment, the kid's IQ is not 2 standard deviations below the norm. And they don't function, they don't qualify for a language disorder a lot of the times. So they're stuck, they're stuck. And they don't get the support that they need with the functional diagnosis. So they might not, what happens is that they might not then qualify for the disability services, the support they need in the courts, the support they need in school, the support they need for disability. It's a serious issue because FASD is a very complex neurodevelopmental disorder, and it's consistent in its inconsistencies. So what we've done in the community, because this is from the community, I came in there, I was just I had done my Ph.D. and I was a diagnostician, and I was doing diagnostic, trained at the University of Washington 4-digit code, trained at the Canadian guidelines in Lakeland Center. We had a team, and our elder brought in these other issues, the generational trauma, all of the stuff that we're talking about, so many different things. So I went home, it was like an inspiration, and worked on this wheel. And the wheel is a holistic way of looking at FASD. And we looked at the indigenous teachings, and with one eye, we considered FASD in the context of generational and family adversity and risk. And let's see if I'll put it there. With the other, we harmonize aspects of the 3 major diagnostic systems, the IOM, the 4-digit code, and the Canadian and Australian guidelines that follow. And this gives us a broader but more precise lens. And on the bottom, you can see it's consistent with those diagnostic systems. You can see that we include physical anomalies. We have, all of the 9 domains are in Canada, so we use the Canadian guidelines. So if PAE is unknown, we use the 4-digit code, because the 4-digit code actually operationalizes, it was brilliant, It operationalizes the diagnosis for complex neurodevelopmental disorder, which is what we call it, when we don't know whether PAE is present. So Fatima would get a diagnosis in our clinic. We use the Canadian guidelines to diagnose FASD because we're in Canada and we fit in with CAN FASD, and we want to fit in with the diagnostic, keep our data, there. If we use the IOM criteria for ARND, because they only have 1.5 standard deviations below, that broadens the lens and allows us to have a neurodevelopmental disorder, but we call it, as they used to do in Australia, neurodevelopmental disorder, PAE, or now in the DSM. So that we can get those children, that's the idea, we can get those children the support that they need. The supports that they need, because diagnosis in Greek means through knowledge. And that's what we're trying to do. We name all of the risk factors. That's the other half of the wheel. And all those little boxes, that's what the elder said. This is a generational condition. We have to consider generational risk because of the past. So we track with our elder on our team, the child, the mother's parents and the grandparents. And we talk about residential schooling and family FASD. There's so many multiple risks, and that's what Indigenous elders and researchers agree. So we look at the multiple risks. paternal drinking, right next to the maternal drinking, and the mothers see that. Their thing is only a small little slice, but they see the paternal drinking, the nutritional, deficiencies, the other drugs, the iron deficiency, which is related to the history, the colonialism, the bad water, the food, gestational diabetes, which then irritates and leads to iron deficiency. And so they need to be brought to light. You're right. They all need to be brought to light, because when we name the FASD, we can work to heal the effects of PAE, but also the effects of the other risks. And we need to track them so we know how it is that it's affecting and interacting, with the PAE. We want to, it's not about curing, it's about healing, and we want to change the outcome, as CJ and Maggie and others in ALC tell us. FASD is an origin story. It's not the end of the story. And what we've seen in the community is we lowered the prevalence rates with this healing model by 50%. We did it 20 years later. We have people that are successful that weren't able to be in school, and now they're back as assistant teachers. And they have kids of their own who don't drink, and they're going off to university. That's the success that can come from naming it. We name it because if we didn't, we would be making it invisible again. We would be casting it into the dark, something that we're afraid to look at. And we can't be afraid, because as the elders say, and Sophocles too, we can sometimes end up creating what we fear. FASD is a disorder, and it's based in disordering. This dysregulations of many systems, the individual dysregulation, the family dysregulation, the community dysregulation, and our work has been to bring this to light, to diagnose so that we can begin the work, as Elder Noel, who's here, says, of rebalancing that wheel. Going. Go on there. Why isn't it working? I'm so technologically impaired. Pardon? It went? The big one, okay, there. Did it go? There. Thank you very much for... So our approach has been successful, like I said, in reducing actually the stigma in the community because of the success that they see. The parents are coming to get their kids diagnosed. It's really working, and I know I know where you're coming from, because it really is an issue, like how this is, And our elder Noel, who's here with us, he can tell you, because he inspired that wheel at one of our clinics, that he continues to keep the spirit alive, both here and also in the province, who are now using this kind of holistic two-eyed seeing approach in all of New Brunswick. There is no shame and no blame in FASD. The shame and the blame belong to a society that isn't dealing with FASD or the adversity that engenders it. The shame of a society with food insecurity, lack of housing, lack of medical care, lack of safety for women, children, and lack of access to FASD diagnosis and to the family supports that should follow. On this, I think we can all agree. We can all agree. So anyway, I am grateful to be here with all of you who are passionate, all of you, and who are knowledgeable and trying to work each in their own way towards healing. And as Elder Noel would say, signogama, all my relations. Thank you.
We're going to have our last speaker. I think because we've run over, we won't have time for audience engagement, but We're here at this meeting to engage with each other throughout the end of the meeting. So Carolyn Hartness will bring us into the end of our conversation.
And
Thank you.
to the speakers. I don't know if I can add much to their fabulous words. So I want to say Osio, which is hello in the Cherokee language, and Wado. So thank you so much for letting me come and present my perspective. And for someone who was raised in an oral tradition, I'm going to be very tied to the written word now. So I apologize that, again, I'm going to read, but I just didn't want to miss anything I wanted to say today. So again, thank you for this opportunity to letting me voice my perspective. And first I want to say that I am not here representing all Indigenous communities, cultures, etc. But I am speaking from my own experience as a Native American in the field and as a mother of a diagnosed daughter and grandmother to 7 diagnosed or impacted individuals with an FASD, including twins, identical twins, one very impacted, one not so much. Before I talk about an Indigenous perspective about FAS, I'd have to talk about the Indigenous approach to life that we have in our communities, and that is the discovering your medicine. That's what we consider our life journey. So what's your medicine? Well, your medicine, it's your gifts, your talents that you came into the world with. And so our lifelong journey is to recognize our medicine, accept it, step into it, and use it. So at this conference, I've heard FASD referred to as a diagnosis, a condition, and or an umbrella term. My perspective is that it's a state of being. They are who they are, not a label. People with this diagnosis condition are beautiful and unique under this umbrella. My daughter, who I met at 13 in a Native American street youth program in Seattle, was diagnosed at 26. She is now a mother of 7 children, most of whom have been diagnosed on the FASD spectrum. She constantly tells me, "Mom, I just want to be normal." And I'd say to her, "Normal's boring. You're really interesting." And I've had the privilege of being part of the UW FASD Diagnostic and Prevention Network for its first 13 years. So I heard hundreds of diagnosed people, children mostly, who said, I knew I wasn't bad or stupid, I just didn't get it. And I heard hundreds and hundreds of parents say the same thing. I knew I wasn't a bad parent, I just didn't get it. So I agree with Jody and Maggie May and others who have expressed their opinions today that diagnosis is a necessary tool. It's a guidepost on the journey to recognizing the medicine that makes people with an FAS so important, but also vulnerable in, as Susie Kirshner says, our process of weaving our collaborative basket of life. In many Indigenous cultures, children are and were not named at birth. They were observed and then named according to what medicine they expressed as a community member. As Susie shared yesterday, her grandmother's words were, "There will be a time when there will be those who come among us who are different, and with their differences, they will change the people." So we are not going to change them, their behavior, until we change our own. So from an Indigenous perspective, these are the special, sacred ones who have come to show us how to be our best selves and are truly our teachers. And I think Liz also talked about them as sacred, and I appreciate that. So as community members, Indigenous and non-Indigenous, let's be excited observers of these amazing teachers and become facilitators on their powerful journey. Let's be part of their success by seeing who they truly are, respect their medicine, value their part in the circle, and listen to and learn from their individual stories. The glass is half full, not half empty. So people we call challenged or disabled were considered to be spiritually endowed, gifts from the Creator, and were often chosen by the community to carry the sacred items in ceremony. They were recognized as being able to see the world through the lens of their purity and innocence, a world that includes them and values their medicine, So let's all come together in a basket of hope and learning, each of us stepping into our medicine to create a happier, healthier world for all of us. Thank you.